Hello and welcome, everyone. My name is Alicia Fletcher, and I am the director of the Delaware Network for Excellence in Autism, or the DNEA. The DNEA is housed at the University of Delaware's Center for Disability Studies and offers training, technical assistance, and information dissemination to community agencies, organizations, and those directly impacted by autism spectrum disorder needs across the lifespan. Welcome to providing neurodiversity affirming care for autistic youth and families. We're very excited and happy to have you here today. A resource guide that accompanies and supplements today's topic will be put into the chat. This and other topic-specific resource guides are free to download on the DNEA webpage. I would like to introduce today's speakers. We have Dr. Kate Bertucci and Dr. Lily Slavin, who both work within the Swank Autism Center at Nemours Children's Hospital. Dr. Bertucci is a licensed clinical psychologist providing comprehensive autism evaluation services, and Dr. Slavin is a psychology fellow providing comprehensive autism evaluation and treatment services. Today's workshop will be captioned, recorded, and posted to the DNEA webpage for further viewing. We'll place an evaluation link into the chat at the end of the workshop. We will also send it to you in a post-workshop follow-up email. Please add any questions to the Q&A. Time permitting, we'll pose them to the speakers at the end. And now I am happy to welcome our presenters for today.
Thanks, Alicia. I'll just share my screen and turn it over to Dr. Bertucci.
Yeah, so we're really excited to be with you all today to talk about this really important topic. Neurodiversity affirming care is so integral to everything that we do in our practice every day, and we're glad that so many of you are so interested in learning more about it. As we jump in and get started, I just wanted to kind of disclose a little bit about myself, and Lily will do the same. So I, as Alicia said, am a licensed psychologist. I work at Nemours. I came up through my training at a time that was not very neurodiversity affirming in general. I feel like we really operated very much from a medical model in a lot of my training, where we really thought of autism as being a pretty significant disability. And we're going to kind of dive into lots of different pieces around that as we go and talk about the medical versus the social model and really what neurodiversity means momentarily. But I just want to kind of put it out there that that was kind of my training background. And so in the more recent kind of years, as the neurodiversity movement has really picked up steam, I've found myself really immersed in this new reality, and now I can't imagine practicing in any other way. I also come and present myself here as a white cisgendered female. So I know that there are a lot of inherent biases and things that come with that. I am also neurotypical, so I do not identify as having autistic identity or any other identities that are under the umbrella of neurodiversity. I think it's really important that we listen to the neurodiverse voices in our community, but I, again, am coming to you as someone who does not hold that identity personally.
Yeah, thanks, Kate. And so I'm just finishing up my training. I'm finishing my fellowship in just about 2.5 weeks. So I've been trained in a little bit of a different kind of world than Kate was, but still the majority of my graduate training really did not have the neurodiversity affirming lens. It was something that I started to hear more about towards the end of my training and going into internship and fellowship. And that was one of the reasons I chose to train at Nemours, is because what I found is, compared to other places I was looking to apply for, Nemours is really at the forefront of trying to provide more neurodiversity affirming care. And so a lot of this work that we're going to be presenting on today is based off of information that we've learned from autistic advocates online or from our colleagues. So I also am not autistic. I identify as neurotypical. I'm also white, cisgender, female. So recognize that we are coming at this with a lot of biases, and we've been trying to check those biases by really listening to the voices of people we're trying to serve. So we are very open to feedback, and we know that there's probably going to be some things where we're going to miss on this, and would really, really welcome anyone who feels comfortable providing that feedback to us so that we can do this better next time. So I will turn it back to Kate to keep us going.
Okay. All right, so we wanted to start by talking through some different definitions associated with neurodiversity in general. Then we're going to jump into some considerations around assessment specifically, and then some considerations associated with treatment. All right, and we have a few different learning objectives for today. So our first one, by the end of this presentation, we expect that you'll be able to describe neurodiversity, those language considerations, and the medical versus social models of neurodiversity. We also expect that you'll be able to explain bias and disparities in the current diagnostic process, and identify neurodiversity-affirming treatment recommendations, goals, and therapies that you can discuss with families. So jumping into the definitions, there are a lot of different definitions associated with neurodiversity in general, but first and foremost, let's define what we're talking about when we're talking about neurodiversity. So neurodiversity really refers to natural differences in the brain among all people that ultimately lead us to experience and interact with the world in a variety of ways. And I think it's really important that we recognize that none of those ways are truly considered right or wrong. Neurotypical people are those of us who generally behave and process information in ways that are considered standard or typical for the general population. So this is kind of the status quo or the majority culture way of kind of seeing and perceiving things. Neurodivergent people, on the other hand, really see, perceive, and interpret the world around them in different ways than neurotypical people. And that doesn't mean that every single way that they see things is different than the neurotypical way. And it also doesn't mean that neurotypical people universally see everything from that standard neurotypical lens. But ultimately, neurodivergent people tend to have a larger number of differences in the way that they perceive and interact with the world around them. And autism is one of the diagnoses that falls under the umbrella of neurodiversity. Many people would kind of consider it to be the primary one. But ADHD is also pretty widely considered to be a neurodiverse diagnosis. And there are possibly other diagnoses that fall under this umbrella as well. There's no like hardcore, straightforward 100% definition where you have to have this, that, or the other. Other things that I've heard of being kind of under this umbrella are things like OCD, for example. And all of the, interestingly, autism, ADHD, and OCD all kind of share some neurocircuitry at the end of the day. So it kind of makes some level of sense that the way that people who have these diagnoses perceive the world around them would be a bit similar amongst them. All right, so the neurodiversity movement has been around for a long time. I think it's been more of a buzzword in recent years, but is not something that is truly new. So the movement really began with an autistic self-advocate named Jim Sinclair. He gave a speech at a major international autism conference back in 1993 in Toronto titled "Don't Mourn for Us." And you can look this up. I actually highly encourage you to do your own little Google search of Jim Sinclair and "Don't Mourn for Us," because it's a really powerful speech that he gave about his experience as an autistic individual and the perceptions. It was really directed toward parents who really felt, or Jim's perception was that these parents really felt like parents weren't very accepting of their child's autism. Like they really felt like it was this terrible affliction and that they wanted it to be something that was cured or removed from their child. And he really stood up and said, you know, autism might not be what you expected of me when I was born, but it's part of what makes me who I am. And it's part of what fuels everything that I do. So if you were to take that autism away, you would essentially be left with the shell of a human, because that's not who I am. Like part of autism is part of me. And yes, there are aspects of it that can be really challenging. He doesn't refute that, but he does want people to understand at the end of the day that it's part of what makes autistic people who they are. And it's really poignant. And then, we have this little exercise here. What does neurodiversity mean to you? So do we have a chat function? Yeah, I think in the chat, or if anybody wants to unmute, you're welcome to. And, any kind of buzzwords, anything that kind of comes up for you when you're thinking about neurodiversity. Like when you hear this word, what kind of comes to mind? Any ideas? You can just drop them in the chat.
So I don't know if folks can use the chat. So they,
Okay.
if you want to put it in the Q&A function, we'll be able to see it. But yeah, I see one coming in.
Okay.
Unique way of seeing the world. I like that. Different way of processing the world and senses. I just got to know autism comes in neurodiversity.
Yeah, we kind of recognize for some of you, neurodiversity might be a much kind of newer concept, and others of you might be pretty immersed in this world already. Yep, diversity, problem-solving strategies, that's a nice one as well. Yep, and seeing and experiencing the world differently, but not, and this part is important, in a wrong way. And that's exactly what we're trying to emphasize here. And really historically, neurodiverse ways of seeing the world have been perceived as being lesser or wrong or inappropriate. And we really want to counter that. And that's a big part of the reason why we're doing this presentation today. Yeah, different people process the world and experience things differently, taking into account all variables of individual interactions and processing. Yeah, these are all really wonderful ideas. Thank you all for sharing. Okay. So language is a big thing that gets talked about in the context of autism in particular, but neurodiverse conditions kind of across the board. So there's this big idea of identity first language versus person first language. And again, I mentioned at the beginning of this presentation that I was really trained in an era that was much more from the medical model of disability. And I was really taught to emphasize person first language. I was taught that identity first language was offensive, actually, and that we shouldn't be using that type of language. And now we've kind of shifted. So person first language is really calling someone like a person with autism rather than an autistic person. So it's saying like this person is their own person, their autism doesn't, that's okay, Lily, but their autism doesn't like define them. It's just one aspect of who they are. So we're going to call them a person with autism rather than an autistic person. Whereas identity first language is kind of the opposite of that, saying, referring to someone as an autistic person rather than using that person first language. Ultimately, there's not really a right or wrong answer here. Preferences vary by individual. So there is more recent research that was conducted with individuals who identify as neurodiverse, so autistic individuals themselves, who have said that, well, a significant proportion of them have said that they prefer identity first language over person first language, but that's not a universal truth. So if you are ever unsure of how to refer to an individual, feel free to ask them. I think that's really the most powerful thing that you can do, is really give people autonomy in being described the way that they want to be described. For purposes of this presentation today, we're going to be using both more or less interchangeably to respect both preferences. So now getting into models of disability. So I've mentioned the medical versus the social model before, but now we're really going to define that for you. So the medical model of disability really uses language that looks at disability as being part of this like normal versus abnormal binary. So people are either healthy or they're sick, and it doesn't really talk much about the social systems that make these categories meaningful or not. Ultimately, the medical model makes some level of sense when you're working in the course of a hospital system or a clinical environment or a school or something like that, where you're really trying to identify like a disabled individual versus someone who's not. But at the end of the day, this type of language can really be damaging for autistic people and can really perpetuate negative stereotypes, because it puts people into this dichotomous way of thinking, that somebody is, again, right or wrong. Someone is healthy or sick. This is bad, and something that we don't want, versus this is something that's different. So when we think about the social model, we're really emphasizing the distinction between impairments and disabilities. So from a social model, we really think of the medical impairments, or what the medical model would refer to as impairments, as socially valued differences at the end of the day. And that ultimately the things that are disabling are the things that are environmentally mediated. So ultimately, there's often a pretty significant discrepancy between what the neurotypical world and society expects of a person and what that person is actually kind of wired, how they're wired to see things and view things and experience things. And that discrepancy between the expectations of the neurotypical world and the way that people naturally are is what causes disability at the end of the day. And of course, there are some co-occurring conditions and things that can happen with autism in particular, intellectual disabilities, developmental delays and things like that can cause disability in their own right. But at the end of the day, for autism itself, the disability is really caused by that mismatch. Okay, and this gets a little bit deeper into those models of disability. So this graphic is really describing theory of mind. So theory of mind being the idea that the psychological concept of being able to perspective take, being able to understand somebody else's thoughts and feelings and experiences. And the research has really shown that autistic people have more difficulty with theory of mind, and that's not a universal truth either, but kind of that was how autism was conceptualized for a long time, that autistic people really have this challenge in understanding what other people are thinking and feeling. And when we use that type of terminology, it really suggests that autistic people lack these key human features, like the normal way of being or the neurotypical way of being able to see or to understand other people's thoughts and feelings is, again, the right way. This positions autistic individuals as being other. It really questions their own autonomy and can really result in a lot of stigma. So, you can kind of flip the script and look at that from a social model of disability. So really looking at what has been dubbed the double empathy problem, which suggests that people who are autistic and non-autistics ultimately have difficulty understanding each other. So it's not the autistic person's problem that they don't understand the neurotypical person. It's equally that the neurotypical person doesn't understand the autistic's way of thinking and understanding the world. So ultimately, we have different ways of processing information. There's a mismatch in that processing, and that's what can cause difficulty. And if we understand this about each other and we can really share our experiences, we can have a much better mutual understanding. Okay. So conceptualizing the autism spectrum within neurodiversity, I think, is also really important, because we know that our diagnostic criteria really comes from a medical model. If you read through the DSM-5, which is our, where autism is defined from a medical perspective, it really looks at deficits and impairments. So, when we talked about that person first versus identity first language at the beginning, for example, that whole movement toward person first language was really forged largely by parents of autistic individuals who were quite vocal at the time. Self-advocates have always been around, but they've had more of a platform in recent years. And so that has helped kind of shift things a bit more to a neurodiversity affirming model. And I don't want to also infer that parents of autistic individuals are somehow not in support of the neurodiversity movement, because that's not remotely true either. It's just different ways of seeing things that have developed over time. With time, we have also increased our understanding of the true broadness of the spectrum. So there, I think for a very long time, and even persisting currently, is a stereotype of autism as being like a certain set of differences and deficits. What we know now is that there are a lot of individuals who don't, quote unquote, look autistic, who do in fact meet criteria for autism spectrum disorder. Masking plays a big role in that. So masking is when someone may, kind of go against their own natural inclinations in order to really fit those neurotypical ideals that we talked about before. And then there are also just stereotypes. There are stereotypes of autism, like autistic individuals not being social, not wanting to interact with other people. The number of times I'm someone who does a lot of diagnostic work. The number of times I've had parents come in and say, the school said he can't be autistic because he's too social. That's like really not a good way of determining whether someone has autism or not. There are lots of autistic people who are quite social. And then a lot of autistic people who go to great lengths to look less autistic just because it makes their lives easier in those moments. So, and you can see that across different environments. Sometimes kids are described as being, or people in general, because autistic people are not just children. I think that's another important thing to highlight. But people can act very differently in different settings. It's like, this is a safe setting where I can unmask a bit. School might be a setting where I need to put on a bit more of a front. What we do know is that at the end of the day, autistic people all have various different strengths and weaknesses, just like neurotypical people do. I think also historically, we've really conceptualized people as fitting into these like high functioning or low functioning labels, and we're really moving farther and farther away from conceptualizing people that way. It's so much more nuanced, and I have a graphic coming up momentarily that'll talk a little bit more about that. We're also moving away from deficit-focused language and really starting to refer to what we would historically refer to as symptoms, as characteristics and support needs, rather the level of support that an individual needs, rather than saying that they have a certain severity of autism. But what kind of unites all autistic individuals at the end of the day, and I think this is important to remember even within the context of neurodiversity, is that all autistic individuals do experience some level of distress related to the characteristics associated with the core features of autism. And ultimately, some individuals, though, have a much more significant level of support need than others. And those support needs change and evolve with time. That's the other important thing to recognize here. All right, and so when we're conceptualizing the puzzle or the spectrum, sorry, you'll see the first image there says, I am not a puzzle. I'm exactly how I'm meant to be. So there's been a lot of pushback against the historic use of the puzzle piece to represent autism, because a lot of autistic individuals felt like that was demeaning. Like, I'm not somebody who needs to be solved. I am who I am. And then on the right there, you'll see a different kind of conceptualization of the autism spectrum, really affecting a variety of different areas of functioning. It's conceptualized in this circle rather than in a binary kind of continuum. The idea is certain aspects or certain characteristics that you see around that circle are things that people experience to different degrees. So some people might have really significant communication differences, while others might have quite mild ones, or minor ones, I should say. Some people, on the other hand, might have more intense STEM behaviors or things like that. Like these things are fluid. They can change with time, and they vary across individuals.
All right, so I'm going to jump in to talk a little bit about intersectionality, and I'm hoping when I play this that you all can hear it, but I may have forgotten to click the share sound when I reshared. One of the reasons that we wanted to talk a little bit about intersectionality is that historically there's been pretty big disparities in terms of who's getting an autism diagnosis and who is not. And a lot of our diagnostic measures and the diagnostic criteria are really geared towards a very small presentation of autism, and thinking about what autism looks like mostly in white children. And so if we're not taking an intersectional lens to our work and thinking about how might we need to be asking questions differently across different cultures and different populations, and how might the interaction between someone who's a white provider and someone who is not white, how that might influence the diagnostic evaluation and the interaction with the child as well. So I'm going to play this, and if it doesn't, Kate, can you just give me a thumbs down if you can't hear it? All right.
Intersectionality is just a metaphor for understanding the ways that multiple forms of inequality or disadvantage sometimes compound themselves, and they create obstacles that often are not understood within conventional ways of thinking about anti-racism or feminism or whatever social justice advocacy structures we have. Intersectionality isn't so much a grand theory, it's a prism for understanding certain kinds of problems. African American girls are 6 times more likely to be suspended than white girls. That's probably a race and a gender problem. It's not just a race problem, it's not just a gender problem. So I encourage people to think about how the convergence of race stereotypes or gender stereotypes might actually play out in the classroom, between teachers and students, between students and other students, between students and administrators, and commit themselves to understanding that as a way of intervening and providing equal educational opportunity for all students, regardless of their identities. Identity isn't simply a self-contained unit. It is a relationship between people in history, people in communities, people in institutions. So schools do a good job when they understand that, and when they commit themselves to curricular development, to opportunities in the school for all students to understand the histories that have brought us to this particular moment. You can't change outcomes without understanding how they've come about. So independent schools can take the lead on that, to be responsive to their student populations and to the communities out of which the students come.
All right, so that was Kimberly Crenshaw who coined the term intersectionality. And on this next slide, we wanted to kind of show how many different levels of identity there are. And we probably don't even include all of them on this slide. But when we're thinking about neurodiversity and the neurodiversity movement, we need to take an intersectional lens to that as well. So when we're thinking about all of these things that are coming up on the screen, so neurodiversity, race, national origin, language, gender expression, disability status, socioeconomic status, gender identity, sexual orientation, education, immigration status, religion, spirituality, age, body size, if we're thinking about all of these things individually and not thinking about how they interact and influence the person that we are trying to assess and help support, then we're really missing the mark. And so another quote from Kimberly Crenshaw: if we aren't intersectional, some of us, the most vulnerable, are going to fall through the cracks. And that's what we've seen historically when we've looking at autism diagnoses and treatment, is that those who aren't fitting into this nice, neat box of autism as it was based on how the diagnostic criteria were created, we're seeing people be missed, and that's really a shame. So it's really important to think about how all of these different aspects of someone's identity are coming together when thinking about someone's neurodiverse identity as well. And so really, when we're thinking about it, it should be all kind of coming together in harmony, and all assessing all of these areas and holding space for all of these areas during an evaluation. So allowing people to show up, families to show up and be themselves and feel welcomed, and holding space to be able to talk about how these things might be influencing the diagnostic question that they might be coming in with. And another quote about the importance of intersectional neurodiversity. This is from an autistic author, speaking, a Black autistic author. So because we're tired of all the people we're fighting, we have to fight them, neurotypical individuals, for our humanity. We have to fight our own people of color without disabilities, because of their ableism. We have to fight white people regardless of neurology because of racism. We have to fight the larger disability community because of the stigma that is associated with neurodivergence. We have to fight our loved ones who mean well, but sometimes just don't get it. We have to fight our employers to be accommodated and respected. We have to fight the media and their frequent misrepresentation of us. We might even have to fight within ourselves to prevent internalizing the hatred and toxicity that surrounds us at every moment. And then we're supposed to fight you as well. You who are supposed to be our kin, our neurodivergent brethren, our community, you who are supposed to make us feel at home. I know the answer. You show me every day that it's yes. At this moment, I am holding on. I'm attempting to channel my inner Langston to declare that I too sing neurodiversity. But in order to continue to sing, one needs oxygen, and mine is rapidly depleting. I just don't know if I have any song left in me. I don't know if I have much more fight left in me, because I'm choking on the noxious fumes of your indifference, white neurodiversity community, and I cannot breathe. So we could do a whole extra topic, talk just on this topic. So we by no means think that this is all you need to know about the importance of intersectional neurodiversity, but we want you to all be thinking about the biases that are in our diagnostic tools and ways that we can go about making assessment more inclusive of people who hold different identities, which Kate will be talking a little bit more on in this next section.
Yes, now we're going to talk about some considerations for neurodiversity affirming assessment practices. So as Lily just said, we do need to be thinking about, and Lily, you can kind of just click through the, I think that's all of them. Yeah. Like we really do need to be thinking about where our assessment tools and everything originated. They originated largely with white cisgendered individuals creating them and everything. And they did come from a medical model, very much so. So we need to be thinking about that when we're talking about any of our diagnostic tools, and we need to be interpreting them with the knowledge of intersectionality at the forefront. And one of the things that we want to be considering, though, when we're thinking specifically about neurodiversity affirming assessment is whether or not the evaluation is really coming from a strengths-based approach. Again, our tools often come from a deficit-oriented model, so we need to be shifting our lens a little bit and thinking about the different strengths that we can assess, and also not considering all of the aspects of autism that we're assessing for to be deficits. I think it's really easy to get caught up in that because, again, that's how many of us were trained, was to think of these as being the deficits associated with autism. That's how the DSM lays them out. But we're trying to shift that thought process there. And then what are the underlying assumptions of the evaluation? That kind of gets at the same kind of thing. What are we assuming by doing this evaluation? What are we assuming about the individual? And can we strike some level of balance between identifying areas of need while also identifying areas of strength for an individual? That's important too. I think we also get a bit caught up in schools and hospitals and other diagnostic centers about focusing on the things that are challenges and the things that need to be addressed, and forget sometimes about really balancing things out with the individual's strengths. We also need to be thinking about getting our information from multiple different sources. So parents may have different impressions from teachers who may have different impressions from the individual themselves. And that doesn't necessarily mean that any of those perceptions are right or wrong, but we need to be thinking holistically about the child or the adult or whoever it is that we're assessing to make sure that we're getting a more holistic view of that individual. And then one of the more important things is how are we as providers framing autism for families? And we'll talk a little bit more about that as we progress through our presentation today. And also what kind of language are we using in our reports? So some recommendations around assessment. When you're introducing an assessment to an individual or to a family, what you really want to do initially is to gauge a little bit of their understanding of autism. Like, where are they coming in at? Some people are going to tell you that they are really familiar with it. They may have other family members who are on the spectrum. They may be autistic themselves. They may have read a lot about it. They may have worked in schools with autistic individuals. Other people may be like, I've heard the word before, but quite frankly, I really don't know what that means. Or they might have an assumption that that all autistic individuals have, a really severe presentation or like severe disability associated, like intellectual disability or something like that associated with their autism, and maybe don't understand, again, that there is a really wide range of presentations. And I think also gauging cultural perspective on autism is important too. So some cultures, there's very much a stigma associated with autism. Some cultures have a more kind of defined expectation of what autism is. We also want to know if it's something that's common in the culture, if the family may know other people who belong to their same cultural background who have personal experiences with autism and things like that too, because that may shift how we're talking about things if we're providing a truly culturally responsive assessment. We also want to put neurodiversity at the forefront of how we're talking about autism with families. So introducing autism as, again, a difference in the way that someone communicates and sees the world is important, and really emphasizing that there's not judgment placed on the questions that you're asking when you're doing a diagnostic interview. So it's not like, oh, well, he doesn't make eye contact, so that's a check in the negative box. Like, we don't want to be coming off that way. That's, again, a difference in how that individual is interacting with people around them, and we don't want to place a value judgment on it. That's especially important when you're working directly with the individual that you're assessing, when that person is present for these conversations. It's so often you hear individuals who were assessed as children kind of talking about their experience of listening to a provider talk to their parent right in front of them, and to talk about them as if they weren't there, and to talk about them as if all of these things are bad or wrong. And we want to do our best to avoid those types of situations. And sometimes as providers, we really need to be cognizant of the things that others are saying about kids in front of them too, in those situations, and kind of steer conversations in different directions as well. And then I think just emphasizing again that the world isn't really set up for autistic people, and that our goal is to really figure out how we can understand and support the individual's needs without changing who they are. And cultural humility is obviously very important in diagnostic assessment. We've hit on it a couple of times. We really want to emphasize or recognize any cultural stigma that the family might experience associated with autism. There are also aspects of culture that really may increase a family's fear around having an autistic child or being autistic themselves. For example, there have been a number of different incidents with autistic individuals and police interactions, for example, and that is just really exacerbated by having Black identity or non-white, being of a non-white racial background. So those types of fears are important to address and to discuss with families, especially as we're trying to present this as something that could really be positive for a child in a family, to recognize that there are very real fears out there. We had talked about gathering information from multiple sources. We want to be cognizant of any potential biases in those sources. We do know that people quite often have implicit bias that they don't even realize is there. There's lots and lots of research out there on teacher perceptions, for example, of kids from different cultural backgrounds and things. So we want to be aware of those things as we're assessing as well. We want to recognize the limitations of our assessment measures. So again, they were largely developed and normed on white populations. So that's important to recognize. White middle and upper class populations. And then we just want to recognize structural and systemic racism. It just exists in general. It exists in all of us, and that we need to be as aware as we can be of our own biases going in, and kind of recognizing that sometimes we'll have thoughts about a particular patient that we're working with or client that we're working with, and we need to kind of step back and make sure that we're thinking of them again very holistically and in the context of their culture. Acknowledging the whiteness of autism can really be a powerful thing. I think historically the kind of public perception of autism was white autistic boys ultimately, and again, as it says there, even the diagnostic criteria and assessments were written based on how white autistic boys usually present. And this does not represent every autistic person. And this can make it feel sometimes as though autism doesn't really fit for a particular child or adult because of that. Asking parents explicitly if they might be interested in resources that are made by and for people from their cultural background. So we actually at Nemours, we have a lot of different resources for Black autistic families. And then just recognizing if you happen to hold white identity, that as a white provider that you might be missing important information that's relevant to a family, and families might not feel particularly comfortable sharing that information. And I like the way that it's worded here as like an actual script that you can use if you're talking to a family, just calling attention to these things. And it's incredibly powerful a lot of times because a lot of minoritized individuals have not had the experience of a white provider kind of calling out the inherent racism in different processes. And then when you're actually assessing an individual, it always helps to ask the patient and the family what you can do to make the evaluation itself more comfortable. So we're lucky enough in our clinic to have lights that can be dimmed, for example. So for individuals who have a sensory sensitivity to brightness, we can ask about language preferences. We can pull in interpreters if necessary and things like that. We often like to encourage the kids to really be themselves in the assessment process and to let them know that this is a safe zone where they don't need to mask. We want to see who they really are, and that we're not looking, again, at anything that's bad or wrong about them. We're just trying to learn more about them and how their brain works and do whatever we can to help them to enhance their well-being. And joining with children during their play can also help them feel more comfortable and give us a better perception. Celebrating autistic characteristics is important too. So as you're doing an assessment for a younger child, for example, you can call certain things out to the family. So I know that like lining things up is something that is often associated with autism, right? Not every autistic person does that, but it does happen a lot. And we don't want to make it sound like lining up is something that's bad or wrong, because it's not harming anybody. It's how the child is expressing themselves. So you could say something like, look at their attention to detail. I love how they lined up their toys. They looked so organized. Same with like stimming. That's amazing. It sounds like they've really figured out ways to regulate their body. That's an important skill. Kids who may have restricted interests, they're so passionate about their interests. Kids who might be a little bit more blunt or forward with some of the things that they're saying. Look, they're so honest and they really care deeply about the things that they believe in. They're true to themselves, even when others are watching. And that's something that often takes people years to achieve. So really kind of framing these things in a strengths-based way. They may still be characteristics associated with our diagnostic criteria, but that doesn't mean that they're bad things and that families should feel like those are things that they need to change about their kids. Okay. Getting into some of the other, like how we do diagnostic interviewing. So instead of asking like, do they not respond to their name? You can ask them something to the effect of, do they get so focused that they're on what they're doing sometimes that you have to call their name several times? Do they have repetitive motor movements? Can be reframed as, do they express their excitement or frustration using their body, like shaking or flapping their hands? Do they play by themselves rather than with other kids? You can ask, do they have a certain way that they love to play? Is it sometimes hard to play with other children because they don't play the same way? So there are lots of ways that we can kind of shift our language. And then when we're delivering diagnostic feedback to families, we could do a whole presentation on feedback. Unfortunately, we don't have time for that. But again, you want to gauge the child and family's understanding of autism. You want to consider all of those cultural things that we were talking about before: stigma, stereotypes, culturally informed understandings of autism. You want to explain what autism is from that neurodiversity lens that we were talking about before. And then I've always found it really helpful to describe the characteristics that you're seeing in that patient that's directly in front of you, patient or family. We work in a hospital, so we refer to these individuals as patients, but patients, clients, students, whatever they may be in your professional context. You want to use direct language and really check to make sure that the family is understanding. So beating around the bush is not really going to help you here. you want to give time for the family to react to what you're saying and to really validate the feelings. I've had a whole slew of reactions. I've had like families that are very sad and upset. I've had families that are angry. I've had more and more families though that really feel like this makes a ton of sense and they're just very relieved to have this answer. I've had kids who've walked out being like, cool, I'm autistic. So there's like a whole variety of different feelings, and I think it's important that we validate those, and we can work to shift some of the more negative feelings into a more positive in a more positive way, or to a more positive outlook ultimately. But all of the feelings are valid at the time that they are happening. You want to allow time to answer questions around the diagnosis and the recommendations, and you want to provide resources. And I think it's also important when we're doing all of this to remember that parents come with their own set of not just thoughts and feelings, but their own set of experiences, and that a lot of parents of autistic kids are autistic themselves, or may suspect that they may be autistic themselves. So, I mean, that it just makes the importance of coming at things from a neurodiversity affirming lens all the more, it makes it all the more salient ultimately. You know, kind of recognizing that we just like, that, you know, we're telling them that their kid is perceiving the world in a different way. They may perceive the world in a different way and need to be, you need to adjust the way that you're communicating with these parents in a way that appreciates their own neurodiverse identity.
Awesome. Thanks, Kate. So now I'm going to take over and talk to you all a little bit about treatment planning and resources, because we know that a lot of our work doesn't stop with the diagnosis. So how can we continue to support the people that we're working with from a neurodiversity informed perspective? And so typically when we're thinking about supports, it's a lot of times they can be broken down into direct interventions and then indirect interventions. So direct interventions are ones that involve a professional working directly with the client and working on skill building for that individual, versus indirect interventions are ones that are working with caregivers to build skills in the caregiver to then make their interactions more effective with the child. And more in the type of work that I do, I've been focusing more on acceptance and identity development, which can really overlap within the two different kind of forms of intervention. So acceptance and identity development, that is focusing on, it's kind of a different approach to treatment that's focusing more on supporting the autistic individual in accepting and understanding their own identity and accommodating the environment to help make them feel more supported. Because, you know, like we've talked about during the assessment procedures, the world is really not set up for autistic people. So there's a lot that we can do to help adjust the environment to make it so that the autistic individual is just better suited for that environment without even having to change the individual themselves. And so I want to talk about a couple different ways of doing this. So in terms of accommodating the environment, one of the first recommendations that usually I recommend to families are trying to increase the structure and predictability of the environment. So it's not a problem that autistic people like routines and have a hard time when their schedule changes. What is the problem is when there's a lot of unpredictability and the environment is set up such that it is really, really stressful for the individual. So we can change the environment to use visual schedules and or use visual supports and use schedules to help make it more consistent. Therefore, teaching the individual kind of strategies that they can use to make sense of a world that is not always very organized. Additionally, thinking about making the environment more sensory friendly. So allowing the use of fidget toys that might be more appropriate to use on a day-to-day basis. Having either a sensory seeking or sensory avoiding room. So if they need a sensory break to have less stimulation, or if they need more stimulation. Using comfortable clothes. So instead of trying to force a child into clothes that don't feel good to them, thinking about ways that we can have them wear clothes that are more comfortable, because we know that already the autistic individual is going to be having to deal with a lot of things that for non-autistic people might seem like, oh, that's no big deal, you can just get over that. It is a big deal for autistic people. And so the fewer things that we can have taxing on their sensory systems, the better. Also reducing the child's need for masking. So that can include respecting their communication modality and preferences. You know, I have a lot of families who come in and they really want their child to be communicating in a specific way, and especially when their child is under distress. And it's so important to really respect where they're at and not make life more difficult for the individual. So for example, that might mean giving forced choices, so yes or no, or allowing them to communicate with hand signals. There's lots of different ways that people can communicate that are just as valid as spoken language. And then encouraging stimming. So a lot of times families will come in and they'll say, oh, look at what they're doing, I want them to stop doing that. And I'm like, absolutely not. We want to actually encourage them to do that, because there's no better way, unless it's hurting themselves, that I can teach that individual to regulate their system and express themselves than stimming. You know, I would much rather focus on increasing their ability to self-disclose or self-advocate, rather than trying to get them to exist in this world in a way that's really not authentic to them. Oops. So these are some examples of some different sensory and visual supports that can be used. So using things like first then statements, having an appointment schedule. I had one child who, when he first started coming to see me, he would just be asking the whole time, like, when am I going to get to do this? When am I going to get to do this? So I made a little visual schedule with him that we would go over with at the beginning of every appointment, and I'd give him some choices too. And he, several sessions in, he would keep on adding several lines down of different things that he wanted to do. And that's great, because that's actually him developing his ability to self-advocate for himself and to have just more of a say in the treatment that he's receiving. So there's lots of things that we can do to make our environment just much more supportive for autistic folks. And so also focusing on acceptance and identity development, moving towards more identity development. For a lot of autistic people, autism is a really important part of their identity, and we should be able to give them the opportunity to explore that. It's so important to allow connection with autistic community, you know, which is inherently probably going to reduce the need for masking. It's important to learn about the culture of autism and what it means to be autistic, and what people that are out there in the world are autistic, and to build pride in their identity. It's been really exciting recently with some children and families that I've been working with. When I start to have these conversations, I'm clearly not the first one to have had that with them, because when I ask them, like, hey, you know, what's cool about your autism? And they give me a whole laundry list. I'm like, that is so awesome to be able to have kids who are already so proud of something that makes them, that's part of who they are. And we know that if that lower levels of masking and greater sense of identity and connection to community are going to be associated with better mental health outcomes later in life. So it's really important to be having this really balanced approach of celebrating the autistic characteristics while also preparing them for some things that they might come into contact with. So teaching skills of self-advocacy and how to find good allies is going to be really important. So this can include teaching to communicate their wants, needs, preferences, and boundaries, but also teaching them that a lot of times, especially for kids, other people are probably not going to listen. So teaching plan A and plan B and what to do when you are speaking, when you're communicating about your needs and someone's not following it. Also considering situations where self-disclosure and requesting accommodations might be necessary. This is especially important for people who are going who are going later on in life and who are maybe transitioning to jobs. And then masking, we know that sometimes masking can be necessary for safety, especially thinking about people coming from more marginalized identities, particularly Black autistic people, and thinking about things like police interactions and school-based and interactions at school and in the community. However, we shouldn't just be teaching kids to mask. We should be talking about kind of when that's a purposeful decision and putting some parameters around it. So not just having interventions to reduce kind of the autistic characteristics. Looking at time, we're running a little short, so I'm just going to start skipping through a little bit and thinking about briefly, we know that ABA is a type of service that is often recommended for autistic folks. And a lot of autistic adults have spoken out that a lot of things that are done in ABA have been particularly harmful. I am a board certified behavior analyst, so I'm well trained and well versed in behavioral strategies. And that being said, I do agree with a lot of the criticisms that are out there about ABA. And so we just wanted to provide some strategies and things to look to avoid some of the more heavily criticized areas of ABA and things that you can do instead. So this is more geared towards parents and thinking about things to avoid, but also as providers, we're kind of as a field moving away from things like planned ignoring, which is ignoring the behaviors that we don't want to see. For me as a practitioner, I'm moving more towards helping that child regulate and developing skills for regulation instead of just ignoring the behavior, because unless you can certainly say that this is 100% for attention, then a lot of times we're probably just leaving a child who needs help to regulate. We want to reduce hand over hand. A lot of times that can feel invasive for children, and we want them to have more autonomy. We definitely don't want to be reducing stimming and repetitive behaviors unless it's a safety risk. And food for rewards is also something that is pretty heavily criticized. So things to focus on instead are really making sure that you're welcoming families into sessions, if you're a parent, making sure that you can see the sessions. Instead of just being an ABA always and forever, using ABA to target specific skills and specific things. Really encouraging for when a young child is saying no, letting that actually mean no and not just overly reinforcing compliance. And then also on just really having a better understanding of comprehensively the disability that can come with autism and how we can help support them. All right, so I really don't have time to go through all of this, so we'll make the slides available to everyone after the fact, but we did want to just draw your attention to some good resources. So we have some books that are available for providers and or for parents and children or adolescents to be used during therapy sessions, and also some more clinical based resources as well. So as a sum, really my takeaway point for the treatment planning is that instead of just focusing on specific skills to teach an autistic child that may or may not be really with the underlying purpose of making them seem more neurotypical or fit in more, we should be thinking about ways that we can be accommodating the environment and teaching skills like coping skills, self-regulation, and self-advocacy as well. And also thinking about accommodations that we can make for the entire family unit. There's a lot of families that I work with where caregivers are also autistic. So thinking about the types of interventions that we're using and how accessible it is to everyone as a whole. All right, so sorry for rushing that. We really wanted to make sure that the assessment piece was the bulk of this, but we'll have some more resource guides coming out for the treatment side as well.
I would like to thank everyone so much for attending, and we would especially like to thank Dr. Bertucci and Dr. Slavin for taking their time to share their expertise with us. In the chat, I hope that you were able to pull out the resource guide that really supports a lot of what both of them spoke about today. This will be recorded and posted to the DNEA webpage, and we look forward to seeing you at another webinar. Thanks so much, and everybody have a great day.